My lady, may I check that you can see and hear me all right?
I can, Ms. Carey. Thank you very much indeed. I'm truly sorry that I can't be with you today, but as you can probably hear, been advised to rest, and if I can't rest, to work from home. So that's where I am. But thanks to the inquiry team who've leapt into action, I'm confident we can proceed without any delays and in the normal fashion, apart from the fact I'm not there. So thank you very much.
Thank you, my lady. My lady, the first witness, and indeed only witness today, is Sir Sajid Javid, who is in the room. Can I ask, please, that he's sworn?
I do solemnly,
I do solemnly,
sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you.
Sir Sajid, good afternoon.
Good afternoon.
You became Secretary of State for Health and Social Care on the 26th of June 2021 until your resignation on the 5th of July 2022. Is that correct?
That's correct.
By way of background, I think you became an MP, first of all, in May 2010. Before that, you'd had a background in investment banking. And do I take it from that you did not have any clinical experience as at the time you were appointed Secretary of State?
That's correct.
We are familiar with the role and indeed the responsibilities of the Secretary, so I don't need to take you through that. But can I ask you this at the outset? By the time you took up the job in June 2021, what was your assessment of the state of the NHS as at the time you were appointed Secretary of State?
Well, clearly, obviously, the pandemic had started and the country had gone through a very, very difficult time, and the NHS had gone through a significant amount of challenges and stress. I think I would say by the time I came in June 21, certainly from the people that I first started talking to in my office, in the NHS itself and others, I think from listening to them at the time that they felt it was sort of things were calmer. There was a sort of better structures in place. The sort of certainly at that point it was felt like the high point of the crisis when there was so little known about the virus itself and how to protect ourselves against it. Things weren't as there were more knowns at that time. But as well as the country still being in partial lockdown. A lot of discussion was going on about when we should lift those restrictions, but also the huge amount of stress on the NHS because of not just obviously people from COVID, many still thousands of infections at that time, but also the pressures of getting the vaccine out as quickly as possible, and the many people we knew that had stayed away from the NHS and wanted them to come forward, but knowing that that would present even more challenges with demand.
When you were sort of gaining an assessment of what everyone had been through and the state of it in June, who were you talking to or taking briefings from?
A number of people. So I had as I say in my evidence statement, I sort of referred to, first there was like a rhythm of regular sort of meetings to both stay updated, but also to help me make decisions. And they would be meetings with number 10 team, for example, with the Prime Minister himself quite regularly, almost every morning, initially in a morning meeting with the team at the department itself, especially certain individuals such as the CMO, the deputy CMOs, the permanent secretary, the NHS leadership, especially the CEO, the chief medical officer, and others, and also Jenny Harries and her team in UK HSA. And there were many other people involved, but what I've stated there are probably some of the people that I would meet almost some of them every day, and some of them more than many times in the same day, but at least every week there'll be very regular meetings.
You said a moment ago that perhaps the height of the uncertainty had passed. Were you able to gain any assessment of how the workforce were feeling, what their morale was like, what their resilience levels were like when you started in June?
Yes, but in the early days, in the first sort of couple of weeks, it was more through, rather than any sort of direct contact with the workforce in the NHS, if you're referring to the NHS workforce specifically, it was through people that were having direct contact. So the leadership of the NHS. I very early on, I also wanted to start meetings with some of the CEOs of the NHS, of the some of the trusts. I started having discussions again early on with some of the representatives of the workforce, the Royal Colleges, the BMA, the Royal College of Nurses, and others.
All right. Before I do ask you about those, can I just ask you about a number of things you say in your statement? And if it helps you, Sir Sajid, I'm at paragraph 41. But you say your overall priorities during your tenure were around 3 key themes: COVID, recovery, and reform.
Yeah.
And I think you go on to say you sought to advocate for greater investment in pandemic resilience, both domestically and internationally. Can I ask, are you able to give us some practical examples of how you advocated for greater investment and indeed what fruit was born from that advocacy?
Yeah, so when I talk about investment, it's particularly, I think I'm referring to here, resources, financial. Resources. Already I was aware that there had been a significant increase of financial resources, both for the NHS to deal with COVID, but also the sort of wider system with other interventions to deal with the pandemic. But more specifically, when I came in, I think that one of my, as I said here, that I sort of framed my role as dealing with 3 things, not sort of one after the other, but they're all at the same time, which is, as it says, first and foremost, right there and then is obviously the COVID pandemic is still going on. There's the recovery from that pandemic. I mean, I wasn't thinking it's over. And obviously later we learned the Omicron variant, for example, comes along. But then also thinking about longer term reforms and also some of the issues that I think the pandemic has sort of shined a light on about health inequalities and other important issues like that within the health system. But to give you a specific example with the sort of COVID emergency and recovery at the time, I was keen to secure extra resources, especially for what I'd call sort of elective recovery from the elective, both in terms of diagnostics and also ops. And I think at the time that eventually, through that process, when it was worked through, I think I secured around an additional £8 billion in that financial year. Some 5.9 billion of that went into what's called the Elective Recovery Fund to fund more operations and diagnostics, and also 700 million pounds into something called the Targeted Investment Fund.
Clearly your efforts bore fruit financially. You say, though, in your statement that you advocated for greater resilience domestically and internationally. Tell us about the international element to your statement there.
Well, it was... So I think when I'm writing that here in this paragraph, I was thinking about international cooperation around COVID specifically at that time, and there were a number of things on my mind, and one of them certainly was prior to me becoming as Health Secretary, the government had already rightly made a commitment to share vaccines with countries that basically couldn't afford them. And I was very keen to make sure that we were following through on our commitment and at pace with other countries. The second thing was about information sharing. The UK had, I think, compared to many other countries, had invested a lot of time and effort in creating databases, including international databases, and I was keen that information was being shared. And then thirdly, I remember soon after I came in that I was briefed on some international initiatives, specifically that the UK had been involved in. One was with the number with the World Health Organization, especially around discussions that are already started on a pandemic treaty, which was sort of looking forward to, how can we be better prepared as a world for the next pandemic, learning lessons. And I think that the sooner we sort of, if there was an agreement on that globally, the better. So that was something I was engaged in. And then lastly, also, there's an organisation called Gavi, which is a global, the global Organisation of Vaccination, Global Association of Vaccinations and Immunisations, which the UK was, I think, probably the second or third largest donor, a very generous donor, and I was keen to see how we could work with Gavi and another similar organisation in vaccinations, and not just the delivery of vaccinations, but also actually getting them into people's arms globally.
All right. Well, that gives us a sense of what you were trying to convey in that paragraph. You do say, though, at your paragraph 43, that you imposed formal parameters around what decisions you wanted to take personally and other areas of decision making which were delegated to junior ministers, and you set them out. You say, I think you wanted to take personal responsibility for the NHS care bill. I'm not going to ask you about that. But you do say how NHS was handling COVID in hospital wards, hospital waiting lists, and prioritisation of surgeries, to name just a few of your areas of personal responsibility. And why those particular areas, Sir Sajid?
Well, I mean, first of all, it's in any government department, it's not unusual for the Secretary of State to set out early on who's going to focus on what, including the Secretary of State. It's worth sort of highlighting this was the 6th government department that I ran, and so I had a bit of experience in running departments generally, but also how to sort of try and get things done. And so so first, this should be happening in any case. But then in terms of deciding who does what, some of it was already set out when I came to the department, and I felt that where ministers were in place, for example, the health minister at the time, Ed Argar, and I felt that it was generally seen that the individual was doing a very good job. I thought that there shouldn't be much change in their mandate in particular. But the areas that I've highlighted here that I picked, and but as you say, this is not a all-inclusive list. There are many others. These are just examples. These are the ones that I decided that were very important for the Secretary of State personally to deal with, because
Can I interrupt you?
Yeah.
I'm so sorry. Can you give us a sense of when you say you want to take personal, what do you actually do? How does it manifest itself in the workings of the department?
So what it would mean is that, if you take, just take one of these diagnostic centres, prioritisation of surgeries, what that would mean is that, I'm referring there specifically to an initiative that we'd had, which was early days at the time, which were around community diagnostic centres. We basically wanted to open up many more diagnostic centres to work for that backlog of people, and they weren't just in hospitals, they could be in other settings. So it's quite a new, different initiative. And I was really keen that that's done at pace. And because it's new, though, issues might come up. And I thought it'd be much quicker in terms of delivery of those diagnostic centres if I was dealing with them directly. So what that means is that every time an issue came up, there was either a policy paper, a meeting to make decisions. It would be me leading that meeting rather than one of my junior ministers.
I see. Thank you. You mentioned a moment ago work that you'd done perhaps with unions, CEOs, the front line. I'd like to ask you about that. In your statement, you say that you had a number of meetings with nurses in particular in February 2022, as that coincided, I think, with a recess in Parliament. Two things. Did you speak to anyone on the front line, though, prior to that, given that you were appointed in June of 2021? What were you doing for the 8 months or so prior to the meetings in February 22?
Yeah, no, lots. In fact, soon after I got appointed, I was very keen to sort of get out there, if you will, out of my office and into hospitals and other clinical settings to speak to both staff and patients, but to sort of get a sense myself and hear directly from people on the front line. And I think probably starting the first sort of week I was in the job, and I would try my best to actually every week to get out somewhere and make a visit, and it wasn't always the case, but that would be my aim every single week. Sometimes more than one such visit in a week, and so I made many visits before the February 22. I don't know how many, but there would even, if it's every week, would have been tens and 20, but also sometimes I would make visits that would, if I'm going to a particular area like Birmingham or something, I might see 2 or 3 different settings in the Midlands area at the same time to try to make the most of my time. But one thing I wanted to do was to make sure that when I made such visits, I wasn't just meeting and speaking to the leadership, which is important. It's hugely important. So I'd go to a health trust, for example. I remember, for example, Milton Keynes, one of the Milton Keynes health trusts I visited, where I had actually a very good meeting with the CEO and his top team. And I think in the past, maybe meetings would have sort of stopped round having those types of top-level meetings. But I had said before I went, and I continue this throughout, that whenever I make such visits, we must try to have meetings for me with the sort of frontline staff, nurses and porters and others, but without any of their senior management present. So I only wanted myself, one of my private secretaries, and then the frontline workers without any of their senior managers, so I could hear from them directly. And I would start often by saying to them, feel free to say anything you want. We're not taking notes. Just be very open and honest, because I want to know what's working well and what's not working well.
Pausing you there, can I ask you then, for example, in relation to the nurses that you met, what kind of things were they telling you? And more importantly, how did that impact your response or directions you gave to the Department of Health? How did what they were telling you translate to actual action for something you could do practically for them?
Yeah, so when I met with many sort of nurses, normally as groups in these typically hospital settings. And I would hear, for example, some things about things that have gone right and gone really well, and nurses, understood the country. It was a crisis, and it was going to be difficult for everyone. But they were on the front line, and I felt that overall nurses were doing a great job, and that they needed to be heard. I'd heard about morale generally. Staff morale was tough, given the burdens, the extra burdens, the pressures that the COVID had brought. And it would lead me then to sort of inquire, when I would then sort of get back to the office, so to speak, and then maybe sit down with the NHS leadership and stuff, is to bring those issues up and ask them what's being done in not just that trust I've heard it from, but in other trusts. I would hear, for example, I remember one group, I can't remember which hospital it was, but nurses explaining to me, it was in an A&E ward, that they felt that their local hospital was very well integrated with the with the ambulance service, and they had some newer technology that allowed them to communicate more efficiently with ambulances where they were and who was about to come in, and they hadn't had that before, and how it had made a big difference to their workday, to the pressures they had. So then I would take that back to when I have my weekly meetings with the UEC team, the urgent emergency care team. I would then be able to bring that up because I'd heard it directly. So there are probably many examples of things that I heard. I found it hugely valuable to have that kind of engagement.
What about in your meetings with porters?
Yeah.
What kind of things were they telling you about how the pandemic had affected them? And again, what did you do about it? What did you take away from your meeting with them?
Oh, well, I think I do remember porters, certainly a group of porters telling me about, and they weren't complaining. It was more sort of explaining that because of the job they had, the very important job that they had throughout the pandemic, and they couldn't stay at home, they couldn't sort of work from home, and they felt much more exposed to the virus. And certainly in the early days, when a lot less was known about the virus, and certainly when there wasn't the vaccine, and in some cases possibly not enough PPE or the right type of PPE to go into those hospitals, they were really concerned. But how they still kept coming into work, and that was before my time. What they were referring to was that before my time as health secretary. But I completely understood it, and it just made me think that obviously I can't change what had happened, especially when they were talking about PPE and the lack of vaccines. But it just again made me think about the next time this happens, when we have a next pandemic, is that exactly the kind of things we need to be better prepared for, but also thinking about people just like that on the front line.
Yeah. In your statement, you make reference to other meetings that you had, including meetings in relation to cancer, and we may look at that. But there was also meetings with those who were involved with patients that had dementia. And can I ask you about that, please? Do you remember now what was sort of discussed in the meetings where you were speaking to people who were involved in dementia? And what kind of issues were they raising with you?
Do you mean in relation to COVID, or do you mean in general?
I think well, your statement doesn't make it entirely clear. It's at paragraph 76, Sir Sajid, if it helps you. You had meetings in relation to monkeypox. I don't need to ask you about that. Regular meetings on cancer with the NHS lead. And then you say similar meetings on mental health and dementia.
Yeah.
And it's really if there's a link between what you were hearing in the dementia-related meetings and how the pandemic had affected those with or caring for people with dementia.
I think what I'm referring to here were on dementia specifically, since you asked about that, is not specifically linked to the pandemic and COVID. My reference here is that if you go back to where we started a moment ago, my priorities, COVID, recovery and reform. And in terms of my sort of recovery, but especially my reform work, was that, as I mentioned a moment ago, I think that for me, certainly coming into running the health service, the department at that time, COVID had revealed, I thought, a sort of a lot of inefficiencies in the system broadly, a lot of inequalities in health outcomes, and I felt also a lack of joined-up government in many serious illnesses. And 3 of those that I identified as a priority were dementia, cancer, and mental health, and actually a 4th one was suicide prevention. But the first 3 I'd spent a lot of time on, and I asked for 10-year plans to be developed, long-term reform plans. But what I was specifically trying to get at is that it's not just a job for the health department, it's a job across government. So, for example, dementia, there's a role for DWP department, there's a role for the education department, for local government, and I felt that government wasn't sort of working together to address these serious ill health issues.
Can we, acknowledging as the wider picture, as you've just alluded to, can I ascend now to perhaps some detail about the NHS itself, and in particular the issue in relation to waiting times? Now, I think you were briefed regularly in relation to different aspects of waiting times, and could we have on screen, please, INQ 000372786, and if we go to page 2, just to situate ourselves. This is a 10-page document which covers a number of different waiting times, A&E, 111 calls, referrals to treatment and the like. I'm not going to go through them all with you, Sir Sajid. But here's an example from September 2021. So you'd been in post, 3 months or so by that stage. And we can see that in relation to A&E, there were 14 trusts undertaking field testing of new standards as part of the clinical review that were not required to submit 4-hour breaches. Therefore, not everyone's performance had adjusted. But if you look at the second bullet point, 95% of A&E standards are not met. 112 out of 112 trusts with type 1 departments missed the standard for all types. And if we just go down to the bottom bullet point, in September 2021, number of patients waiting over 4 hours was 104,000 odd, and over 12 hours there was 5,000 people for a decision to admit to admission, the highest recorded since the collection began. Now, Sir Sajid, clearly A&E waiting times, ambulance waiting times and the like are nothing new, but would you agree they were exacerbated by the impact of the pandemic?
Yeah, absolutely.
And
the primary cause of these very poor numbers is the pandemic.
Now, seeing that bleak picture as you did, I think, on a regular basis, can you help with what steps you took, for example, upon receipt of this information to try and improve A&E waiting times, insofar as you were able? And we appreciate that there's not a magic wand here, but tell us, what kind of things would you say, would you do, would you direct the department to do about this?
Yeah, I mean, so first of all, I thought it was important to understand why is this happening, and obviously I think it's obvious it's the pandemic, but then we need to break that down. What is it? What aspects of the pandemic are driving this? And you had this combination of people coming to A&E that might be related directly to COVID, and so they might be in really bad health, need emergency care because they've got the virus and it's been particularly bad for them. But also, and this was going to be a huge amount of it, is that this is, as you say, September 2021. By then, I think I'm right in saying that all the sort of lockdown restrictions had all been lifted. There might be other restrictions in place, but the country was feeling like it's sort of getting slowly back to normal. People were out and about again and things, and feeling, I think, more comfortable to access healthcare and weren't sort of keeping themselves away like they had during the height of the pandemic. So a lot of people were returning to healthcare, and a lot of the problems they would have had, that had there not been a pandemic, they might have gone through their usual sort of process in the NHS without A&E. Maybe the issue had become more acute. So I think there was a lot of, like, what I would say is sort of delayed demand even for A&E. Also, I think a part of the aspect here, part of the reason here was accessing non-emergency care, and people getting frustrated that they maybe tried to get hold of their GP or other forms of non-emergency care, but they tried so many times and feeling that they're not getting through and the system is not responding well enough, and then turning up at A&E, whether that's through ambulance or at the door. And so the answer to your question about what we were trying to do is that I had a number of meetings with NHS, with the department, and ambulance trusts and others about this particular issue. And then I think it was in September that same month we published a 10-point plan on a UEC on an emergency, urgent and emergency care. And that included a number of initiatives. So, for example, one of those that sort of stood out, I was told, was one of the biggest issues was more people, if there were enough call handlers, qualified call handlers, more people could be handled through the NHS 111 service.
I come on to that.
And so that was one thing that we invested in terms of resources and trying to trade up more people. Another was through what some more support could we give to primary care, to GP services, and that then this fed into, I think later, the sort of the winter care package. I forget the exact name we called it, the extra 250 million, the winter fund that we offered GP services, and then also we were. In fact, on this issue, I also felt I needed more data. I needed more granular data, which I started getting what I sort of called a UEC sort of dashboard, and then I started asking for it at least a day before the meeting so I could study it before I'd have my meetings, and I started having almost twice weekly meetings on this particular issue to see and make sure that we were doing everything we possibly could be doing.
Can I pick up on one of the things you just said there, which was NHS 111?
Yep.
And in fact, if we go to page 4 of this document, we can see that some of the other aspects of waiting times that you were given were the number of calls going into NHS 111. And indeed, some of the data, if we look at the middle of table 5, was the proportion of calls that were abandoned. By September 2021, it was 25.6% of calls abandoned. And just to help you, Sir Sajid, in March 2020, we heard that there were, I think, 1.1 million calls out of 2.5 million calls that were unanswered. So 40% went unanswered 18 months before. It's now down to 25.6%, but still a large proportion of calls that were abandoned. That's not to say people might not have rung back. We appreciate that. But do I understand it correctly that even as at the time that you became Secretary of State, there was still concern that NHS 111 didn't have the capacity to answer the calls that they were receiving?
Yes, absolutely.
Yeah. And do I take it from what you've just said that you tried to do something about that by increasing the number of call handlers?
Well, yes, cool. And also there was the increased number of call handlers, and I believe there was also something where some kind of initiative with British Telecom as well about how how the calls were handled and distributed around the country.
Final page on this, if we go through please to page 8 of this document, you were receiving information about the post-COVID assessment service, or long COVID.
Yeah.
And we can see that as at September 2021, in August there had been 5,488 referrals. That was a slight drop than in the previous 4 weeks. The proportion of those that were accepted, one looks at, they were telling you the access, the types of people that had been assessed. Clearly there was mainly white people. Most of the people were women. And then the age groups, indeed. And you can see there that, in fact, 1,000 of those, 31% were under the age of 45. and then the majority of people there were aged between 45 and 64, and a smaller percentage aged 65 plus. And then if you look at the waiting times, of those who'd had their initial assessment during the reported period, 40% were seen within 6 weeks, 55% within 8 weeks, and 19% were waiting longer than 15 weeks. And then there was regional variation. So it looks like they were doing better in the northwest at being seen within 6 weeks compared with what was going on in the southeast. So clearly a lot of data there about long COVID. When you saw regional variation like that, what do you actually do as Secretary of State to try and address what on any view is a wide disparity, isn't there, between how the northwest was performing and how the southeast was performing?
Do you mean with reference to long COVID only?
Yeah, long COVID.
Okay. Yeah. So I would want to know as to why. What are the reasons for such a disparity? And so for example, could it be the provision of services? Could it be the communication of the? Could the service exist, but is there poor communication? And obviously there could be other issues as well. And then what we are doing, we sort of more broadly, but specifically NHS, to address them. I noticed this was in, I think these numbers, as you say, it's from August.
Yeah.
And I believe that throughout the pandemic, but I think particularly in June of that year, there was a big sort of I think, announcement by my predecessor. It would have been around long COVID, but in particular about more provision and more resources. And I think, if I remember, something like £90 million was allocated for more clinics specifically for this, and something like 145 hubs were stood up across the country. So I knew that. So looking at this, I would have known that, but I would have wanted to sort of be updated that what's now happening is that money actually going into creating the hubs, because we had no time to waste. You didn't want an announcement back in June, only a couple of months before this, that people sort of perhaps sort of haven't understood the urgency of that, and I think I would want to be updated on making sure that those hubs are indeed opening, they're operating. Are there any issues? And so it's not just an announcement that maybe is the right announcement, but is it actually being delivered?
Can I stick with long COVID?
Yeah.
And I think by the time you had become Secretary of State, there had been various pieces of guidance and calls for research, and indeed funding for research, as you've just referred to. You're right that in June, Mr. Hancock had launched the long COVID plan for 21 and 2022, including the 19 million on COVID clinics and various other amounts of funding. And I think in July 2021, you announced 15 new studies and just shy of 20 million to help improve the understanding of long COVID and identify effective treatments. Can we just look at some of the projects that were being envisaged? And can I have on screen, please, INQ 283460 _ page 4. And this is just a summary of some of the projects, but you can see that there was one being done by University College involving more than 4,500 people with long COVID to test the effectiveness of existing drugs to treat long COVID. Yeah. And then there were various other studies, including, for example, the locomotion study at Leeds, focusing on identifying and promoting the most effective care. And indeed, one being done at the bottom bullet point, Explain, at University of Oxford, looking at diagnosing ongoing breathlessness. Can I just ask you this? Were you involved in actually identifying what projects should get the funding, or just securing the funding itself?
More in securing the funding. And I think I'm certain what would have happened here is that once the officials working with the NHS and stuff had identified which projects are to get funding, I would have seen a list, but I would not have changed it or made any other recommendation on the basis that the officials would know better, because they would have had the expert advice and they'd understand each of these. I would have been keen for them to get on with it. I do remember, because the funding for all this, I think, was announced, as you say, by my predecessor in June. These studies you're referring to, this announcement, these 15 studies, was made soon after I got in, like a couple of weeks after I got in. I think I'm pretty sure that within my first few days, I asked about certainly I had a briefing on long COVID, but I asked what was happening to the funding, and I wanted the team to sort of accelerate this investment, because again, I didn't want there to be an announcement with no follow-through, and I'm sure because this happened quite quickly, I would have been pleased that they've identified the projects and started to get them funding very quickly soon after the announcement.
Right. Now, we've heard that there were long COVID roundtables that were already in existence by the time you became Secretary of State, and I think you attended one yourself on the 23rd of September 2021. We have a minute of that. Can I have on screen, please, INQ 4067049? I think they were normally chaired by Lord Bethell. You attended this one. And in the ONS update, we can see there that it was reported that prevalence of long COVID at 12 weeks was highest amongst women, middle-aged people, and people with existing illness. And then if we go down to the NHS England update, and the note that starts, CH said that based on data from September, there were 6,000 referrals to the assessment services over a 4-week period. 88% were accepted. The rate of referrals is only around 30% of what was anticipated, which may mean many people are not coming forward. Now, once this was being discussed in the round table, Sir Sajid, what did you ask to be done about this, and why, on the face of it, it looks like there are quite a large number of people not coming forward for assessment?
I think actually one thing I'd point out here, there were, as you say, there were regular round table. A task force was set up. In fact, I think the NHS had set up their task force back in 2020, and from ministers, there were regular round tables. Also at this meeting, I think I'm also right to say that Maria Caulfield was there as well, and she was a minister in my department that was responsible broadly for patient care and patient safety. And one of the jobs I'd given her when she had come in as minister was to also be the minister for long COVID, because I thought it needed a very specific focus from a minister. And I believe she was at this meeting, and she regularly attended these meetings. But on your question, I couldn't tell you today, like specifically in relation to what's just highlighted here, what I would have asked, but I can tell you with a high degree of confidence what I probably would have said is, how do we, there are clearly people out there that should be coming forward that are not. So what are we doing? What is the NHS doing? What is the department doing to try and encourage them? And this was, actually, it was a broader problem. It wasn't just an issue with long COVID, and that's important enough. We had a very big issue of people not coming forward, and that was important to me. Because first of all, if people have some illness that needs to be addressed, the sooner they get it addressed, it's good for them. Obviously, it's better overall, so for the NHS as well. But I just felt that not enough people were thinking that the NHS is sort of open, so to speak, and they can start coming back now with the issues they might have stayed away from at the height of COVID. And in fact, I made many public appeals on TV, radio, media, elsewhere, again and again, just asking people to come forward, and that would have included people clearly that might have symptoms of long COVID.
Can I just ask you, stand back slightly away out of long COVID for a moment? We've asked a number of people, indeed we've heard a lot of evidence about the stay-at-home messaging and whether the balance was right. And you were, I think, Chancellor of the Exchequer at the very beginning of the pandemic, and then were in the backbenches for a while before resuming your role as Secretary of State now for Health. What do you think, Sir Sajid, about whether the balance of the stay-at-home messaging was right, and would you do anything different if you were, or advise a future minister to do anything different?
Look, I think it was overall, in principle, it was the right messaging. I think what's very difficult is what you've just said, is the balance, getting that right, because it needs some kind of clarity, and I think that most of the time that was there, but I think then later on during the pandemic there were moments before, this is moments I'm referring to before I was Health Secretary, and I speak now not as therefore as Health Secretary, but I was a backbencher, as you say then, but I felt that some of the messaging could be a lot clearer. But I do, having said that, I just think it is very difficult to get the right balance.
Yeah. I think everyone acknowledges the difficulty, but a solution is perhaps harder to find. Can I go back to long COVID, please? And in that round table in September 2021, if we could go to page 3 of that document, I think you actually then spoke to and were addressed by a number of long COVID sufferers who spoke about their experiences. It's just coming up now. And we can see there in that top box that a sufferer explained that she was from Manchester, one of the 6 most deprived areas, had caught COVID early on in the pandemic, was disbelieved by her GP who dismissed her, and months later was still suffering. She said she's now been referred to the long COVID services, often not been able to travel to multiple different hospitals for appointments. The model of service is not accessible for many people who live on a low income or are disabled. And indeed, reference there to online support groups being set up, and then regularly hearing from people who were saying they were disbelieved by their GPs. Once you heard it from the sufferers themselves, can you recall now what you did to firstly address concerns that people were being disbelieved by their GPs?
Yeah, I was actually, I remember actually now hearing that, and I was very concerned about that. But I'll tell you, one of the reasons it sort of particularly caught my interest is that, I know people that suffer or live with ME and CFS, and I know that's not long COVID, but it is a serious illness that affects at least 200, maybe 250,000 people in this country. It's a very serious illness. Actually has some symptoms that are not dissimilar from long COVID. And just from my own sort of personal experience, I've heard from so many people, and also as a constituency MP, that people that are living with ME and CFS felt that in some cases they'd say GPs are not listening, they don't recognise it, they think I'm just lazy, I should just get out there, do a bit of exercise. And this comment that this individual obviously is making about long COVID really reminded me of that. And I saw some sort of similarities in that. And I thought one of the issues with ME and CFS is that it hasn't received enough research, and because it hasn't been by the system being taken seriously enough by everyone, and that's what was something that made me want to act even more than otherwise on this, because I really recognised what this individual was saying, and I'd heard it before as well with reference to long COVID as a constituency MP, and so as a result of that, I certainly would have wanted. One thing we already talked about was the research, trying to how can we sort of make sure this research is happening. But also, I think I inquired then about what is the NHS or the health system doing about this, making sure, for example, GPs do know about this, that they do take it seriously. And I was told that for example, that NICE was setting out new guidelines. It had already had guidelines on long COVID, new guidelines, and also how it would be communicated. I'm sure I would have asked it to come out even sooner than what they planned, and I believe that in November that year that NICE did publish its guidelines, and the point being that it gets out to every clinician and practitioner out there, so there's better awareness. I also, by the way, started a separate review of the government's handling of ME and CFS as well, and I asked them to work closely with the same team that was looking at long COVID.
Can I just jump forward a few months and look at the waiting times in relation to long COVID again? And could we have up on screen, please, INQ 479860_9? And Sir Sajid, this is now January 2022. We just looked at September 2021 data. And if possible, could I have up the September 2021 data? It was INQ 372786, I believe. So on the left of the page, if you're looking at it, waiting times from September 2021, as we just looked at. On the right side of the page, here we are now in January 2022. And if one just looks at both the bottom waiting time boxes, in fact, it looks like the position's got slightly worse in some respects, better in other respects. But we can see there during the reporting period, 39% now waiting 6 weeks. I think it had been 40%, so it's got better by percentage. 55% down now to 47%. 35%, though, were waiting longer than 15, so it looks like a rise there in the amount of time people were waiting. And there is still the regional variation. length of waits, 81% in North East were being seen within 6 weeks, compared with 4% in the South East. 64% of patients in the South East were waiting over 15. So may I put it like this, a mixed picture of some progress in some of the waiting times coming down, assessment times coming down, but not in other respects. When you got a sort of jump like that 3 months on where it's not improved across the board, what did you do as Secretary of State to try and ensure that those great disparities that we're seeing there in regional variations were addressed? It looks like something hasn't quite worked from September 21 to January 22.
Yeah, I would have seen these updates on activity regularly.
Yeah.
I think part of it probably also reflects the number of people, because one's obviously a few months after the other, and so the number of people, sadly, with long COVID is probably increasing as well, because just the way the virus is. Because I think the second set of numbers is during the Omicron. It's 22nd November to 19 December,
Yeah.
so that's during the Omicron wave. And so infections have been rising as well. I think I would have. I mean, again, I can't tell you specifically in relation to this what I did, but I can tell you what I sort of would have done is to ask about the resources, and are we putting enough resources into this? Or all the hubs being stood up? Is there enough awareness amongst GPs to recommend people to the right services? And I must also say that I think that during that time, this period, November 22, 22 November to 19 December, I think a lot of my sort of bandwidth, so to speak, would have been on Omicron.
Yeah.
And perhaps I would have had less time to spend on other issues, no matter how important they are, because Omicron was a serious threat to the country and the NHS.
We're going to look at Omicron in just one moment.
Yeah.
Can I just finish on long COVID, and can I ask, please, about some comments that the Inquiry's Every Story Matters record has heard? And can we have up on screen, please, 474-233_0180? And the section beginning other pandemic changes to healthcare made it harder to access care for long COVID, adding further frustration. For some experiences highlight the difficulties faced in using a telephone or online consultation to communicate their symptoms. Contributors were frustrated that telephone or online appointments did not provide care to the same standard as seeing a healthcare professional. And you'll see there, Sir Sajid, 2 quotations from people that spoke to Every Story Matters. The first person said, "It's so hard to see a GP now. I have to send photographs to my doctor's WhatsApp group. My GP surgery has a WhatsApp telephone number where you send your name, date of birth and the photographs. It's just not the same." And the second contributor said, "I managed to see healthcare professionals through virtual consultations. They instructed me to monitor my own vital signs like pulse and blood pressure, and even guided me through examining my own throat. But I found this mode of consultation inadequate. There's no substitute for a physical examination by a professional. I was diagnosed with long COVID. Whilst this diagnosis was a relief, it also taught me a crucial lesson. Virtual consultations have their limitations." Were you made aware, firstly, in the context of long COVID, that perhaps in some respects virtual consultations were having an effect on those who were seeking diagnosis and or treatment for long COVID?
I don't remember specifically with reference to long COVID, but I was made aware more generally, and that would have included long COVID, that virtual consultations have their limitations.
Well, it brings me on to that topic, if I may, because I think you've certainly seen evidence provided by the Royal College of GPs, and indeed we heard from Dr. Mulholland. And can I have a look on screen, please, at INQ, I think it's 4097867. And we are now in, I think, September of 2021. So just before Omicron really hits. And if we go down in the letter to you from Richard Vaughtry, the chair of the BMA's GPs committee, clearly there's reference there to GPs, practice managers and other primary care professionals share patients' frustration when they face long delays for an appointment or waiting times. BMA survey revealed that 2/3 of GPs said they'd experienced abuse, including threatening behavioural violence, and that had got worse in the last year. And indeed, there was another survey done by the Institute of General Practice Management that found that there was GP staff experiencing abuse, not only that, threatening behaviour, racist abuse, sexist abuse. When you received this letter, if we go over the page, there is a request for you. Thank you. The paragraph beginning, "The situation is not acceptable. We call on you to publicly support and defend dedicated GPs and primary care staff against this onslaught of misinformation and abuse promoted by the media. It's essential that patient care is protective. We believe that there must be accurate, timely and regular communications from the government to the public which reflect the realities of the situation." Now, no one is obviously doing anything other than condemning abuse of staff and GP practices, but there was a call on you to publicly support and defend dedicated GPs. And did you do anything in response to this issue being raised with you? And if so, what?
Yes, I mean, and sadly, this wasn't the only time this issue was raised with me, and this was an important letter, and I totally understood why it had been raised with me again, and actually having these numbers they were shocking. It was good, in a sense, it was good to have some numbers around it and get more information, but they were shocking numbers because, as you say, abuse of, whether it's doctors or any health professional or anyone, is completely unacceptable. But in a situation where, in this case, it was talking about GPs in particular were facing so much pressure and challenges, and clearly they couldn't operate in the same way they had done pre-pandemic. And I think it's fair to say the vast majority of the public completely understood that and worked with GPs, but there were sadly cases of abuse. I remember one case in particular there are many, but the one I remember in particular was a very horrific case in a doctor's surgery in Manchester. And when I heard of that particular case, I happened to be going to Manchester in any case that same day or the day after, and I made a visit to the surgery and met staff and met others. It's an issue that I and the department and the NHS took very seriously. We talked with representatives of GPs about what more we could do to try and give sort of security and comfort to GPs, but also publicly, whether it's in Parliament or elsewhere. I would have said that this kind of behaviour is completely acceptable, and that people must recognise that GPs are under a lot of pressure.
I think you are also aware that RCGP were concerned in September 2021, where you said in Parliament that more GPs should be offering face-to-face access, and we intend to do more about it. You said that it was not intended to create a league table, but it appears certainly that was how it was potentially reported in the press, and that many members of RCGP felt demoralised by what they perceived as a constant media attack and a lack of support from the department and indeed from ministers. Can you help us? What were you trying to achieve when you said more GPs should be offering face-to-face access, and we intend to do a lot more about it?
What I was trying to achieve is that I think during in 2020, when we all first learned about the pandemic and the stay-at-home sort of requirements came out, there was no vaccine, or it was very early days of the vaccine. I think that at that time, everyone, including the general public, GPs and stuff, understood why it's not really going to be possible for almost anyone to see their GP face-to-face, unless there's some kind of emergency situation or something. I think that people expect most consultations to be virtual or trying to avoid face-to-face contact. By September, the period that you asked me about when I made that comment, in September 2021, we were, as a country, thankfully, we're in a lot better place vis-a-vis the pandemic in terms of vaccination, other treatments, and also the stay-at-home requirements, other sort of limits on social interactions almost all of them had gone. And I think there was a reasonable expectation of the public that it shouldn't be as hard as it was to get a GP appointment as it was in the previous year, and as a face-to-face appointment. Now, that said, I felt that, in a vast majority of cases, and especially for those patients that believed they were adequate, that virtual appointment is perfectly okay and it works. But in some cases, it might not be the right type of appointment and it might not be adequate. We've just seen an example that you've shared with me from someone who had long COVID, who felt that had it been face-to-face, maybe there'd been a better outcome. And that's what I was reflecting in that statement. And also at that time in Parliament, amongst members of Parliament of all political backgrounds, it was one of the number one issues that MPs would bring up with me, either formally or in the lobbies or in even the tea rooms and stuff. What is the government doing about bringing back more face-to-face appointments? And that's MPs reflecting what their constituents are bringing to them, particularly elderly constituents who, whether it's the technology or otherwise, found virtual appointments incredibly hard. Doesn't mean to say they can't work. And for many elderly, it was on the phone. So it wasn't like a video conversation that you might have, say, for a younger person that has access to that kind of technology or is comfortable with it. It would be a phone call from a GP, and clearly for someone that has a number of ailments, having a GP call on the phone may not be adequate.
Given that you were hearing from a number of different quarters about the concerns that it wasn't working, do you think enough was done to try and convey to those who would prefer face-to-face appointments that was still an option available? We've heard there was a perception, certainly, that people couldn't get a face-to-face appointment. Could more have been done to dispel that perception, do you think?
I think it mattered where you're on your GP surgery. I mean, there were some surgeries, even at the time I made that statement, that were doing virtually no face-to-face appointments. And in other parts of the country, it was a realistic option. I think what I wanted to see, what the NHS wanted to see, because it pays for those GP services, was where possible. Obviously, ultimately, the GP has to be the judge of that, rightly so. But where possible, and where a patient was requesting a face-to-face appointment, the GP should do that if it was safe and right to do so. And so there's really almost like some kind of postcode lottery, depending on where you were, what kind of GP surgery that you were registered with, whether you were going to get a face-to-face appointment, even if you had requested it.
May I move to Omicron and the planning for winter 2021 into 2022? And in Module 2, you gave evidence that in relation to the planning and preparation for indeed Omicron and that winter, the NHS was a huge factor in this. We wouldn't want to see our hospitals overwhelmed. That's what you said to Module 2.
Yeah.
What did you understand NHS overwhelmed to mean or to look like?
It would have been the NHS unable to cope with emergency cases, A&E, effectively becoming closed because it was had too many patients, ambulances not able to arrive and drop people off in any kind of reasonable time. Just to sort of to explain that a bit more, even in pre-pandemic time, so just before the pandemic, the NHS is traditionally run on a very tight sort of capacity constraints. I think roughly about 95% in terms of beds, if you measure it like that, and that's a lot tighter than comparable countries. And so there's not much sort of there's not much give in that. And obviously the pandemic came along, and that meant. The NHS didn't just have much capacity, whether you measure it in terms of beds, doctors, nurses, and I felt that, a year on, which is just over a year on, when I was in Secretary of State, and Omicron had started, and when I learnt that it was that the key difference between Omicron, the first thing we learned about it, before we knew it was less severe, which obviously was welcome news, before we knew that, we just knew that it was a lot more contagious. And that's what really worried me. And that's why I was concerned about the rate it was spreading. If it turned out that it was severe or not enough people had vaccines or the vaccines weren't going to work properly, that the NHS may become overwhelmed.
we've heard a lot about NHS overwhelm.
Yeah.
And it may be thought to be a rather subjective word. What is overwhelmed to you may not be to the nurse on the front line and some indeed the witnesses that we have called. Do you think now, looking back, that it was the right word or the right way of describing the aim to protect the NHS?
I mean, I don't. If you didn't have that word, I think you'd probably come with something similar, and you'd probably ask me the same question about that word.
It's just that it might be thought that if you're cancelling all non-urgent elective care, that is an example of the system being overwhelmed.
Yeah, I mean,
it might be thought that if you are making difficult triage decisions about who should go to hospital, who should go into intensive care, that is an example of overwhelm. And I just really wanted your reflections now, some years on, as to whether you thought it was a helpful way of looking at and conveying the real state of the NHS during the pandemic.
I don't think it's unhelpful.
In your statement, you set out a number of the contingency measures that were put into place to prepare the healthcare system for that winter of 21 into 2022. And I'm not going to go through them all, but you say at your paragraph 100, Sir Sajid, that some but not all of the contingency measures that were formulated for the autumn-winter plan 2021 were helpful in preparing the system to respond to the pressures of Omicron. Can I ask you, what measures do you consider were not helpful in preparation for Omicron?
I think that's probably a reference by me to, I think some were, I mean, I don't have them all in front of me now, but some were more important than others. It's not that they were it's not that they were completely unimportant. I think there were some measures there that we'd set out in the winter plan that are the ones that should be focused on.
Right. One of the factors that was taken into account was workforce absences. It was clearly higher during COVID than it had been pre-COVID. And you say this in your statement: there was a reserve programme launched in November 2021, and you considered that having a reserve scheme on standing basis is helpful in the times of crisis. By and large, it was kept in place and still exists now, with the head of the NHS announcing an extension until March 2022. You leaving, I think, later as your role as secretary a little bit later that year. What for you was the main benefit of having that reserve programme? And do you think it would be useful in the event of a future pandemic?
Yeah, I think the main benefit was just, to take its name, is that if you have experienced clinicians on reserve, so to speak, and then you know who they are, what their skills are, where they are in the country, and other factors, then it's something that in an health emergency situation such as a pandemic, it's much easier for the NHS, for the health system, more broadly, to ask those people if they're able to serve and if they're able to help, if it's been well thought of in advance. So the second part of your question, is it helpful to think about something like this sort of going forward? Yes, it is.
We heard from Amanda Pritchard from NHS England that planning for the winter started in June 2021. But by December, when Omicron had really started to take hold, there were concerns about the response because there were in fact far fewer beds available now because there'd been an attempt to resume non-urgent elective care. Clearly there was some availability of some Nightingale units, Sir Sajid, and you say in your statement, at your paragraph 102E, you were informed that the way in which Nightingale hospitals were set up during the first wave had not been effective as a primary reason was we simply didn't have enough sufficient doctors and nurses to operate them. And then you discussed that with Amanda Pritchard. Just pausing there, who informed you of the fact that there weren't enough doctors and nurses to operate the Nightingales?
Oh, I think it would have been more than one person. Okay. I'm sure Amanda told me that. I'm sure the chief medical officer told me that. The national clinical director. I mean, it was well known that there weren't enough staff to there's doctors, nurses, or other clinical staff for the so-called Nightingale hospitals. At the time of Omicron, and learning from that experience, what I had, the suggestion from Amanda and her team, which I thought was sensible, was that what could be done to help the NHS with capacity was to sort of extend existing wards rather than have completely new wards or so-called sort of Nightingale hospitals, and to focus them on sort of I think what they refer to step-down care, so still care, medical care, but maybe less demanding than otherwise, and therefore staff could be proportioned adequately. And I think the NHS started calling them surge wards. I think the name Nightingale was tagged on to that. Didn't really mean anything other than they were just sort of surge wards, but that's how we handled it during Omicron.
And were you satisfied that surge wards, Nightingale units, call them what you will, that there would be sufficient staff to help ensure that decent levels of care were being provided in those surge wards?
Well, it turned out that way, but really I didn't know at the time when we decided that, because I didn't know what was going to be the path of Omicron, and I quickly decided within a couple of weeks of learning about Omicron that the way out of it was through pharmaceutical defences, especially through boosting. But we had to boost in record numbers of people, and also we had to get record numbers of tests out there, and also make sure we had the antiviral stuff, which we all did successfully in the end. But I think, had it not been from that, then perhaps the staff numbers wouldn't have been enough. I also just want to add, you asked me about winter preparation, that even before we knew about Omicron, just knowing that winters historically can be tough. And also we had information about the flu and the seasonal flu, and what we tended to do was to look at how flu had performed in the southern hemisphere, and that would give a bit of indication of what might happen in the northern hemisphere in our winter. And I was concerned that it could be quite a difficult winter, obviously not knowing about Omicron at the time. But we put together a winter sort of access package for GPs. And there's £250 million of funding available for GPs and a whole sort of program of support. And I was very disappointed that when we took that to GPs generally as individuals really welcomed it in my interactions with GPs, but the BMA's General Practitioner Committee was very much against it and didn't recommend it. And that was very disappointing, because I felt that they weren't putting the interests of patients first, which is what I would have expected in a time of national crisis.
All right. Final document, please, before we perhaps break for lunch. And if I may, could we just have up on screen, please, INQ 270035_4. So Sajid, this is an Omicron NHS planning meeting, or I should say a note of that meeting on the 7th of December 2021. I won't take you through all of it, but you can see there that you're present. There's a number of names that are familiar to us now present. Clearly there was concern about the transmissibility of Omicron, and AP Amanda Pritchard setting out a number of actions underway to try and ensure there was sufficient capacity. And could we go to page 4 of that document? And there you are, thank you very much. Secretary of State queried NHS's capacity to respond to a 25,000 scenario. Was that envisaged 25,000 extra patients?
25,000 total.
Total, all right. Triggering escalation to level 4 at the NHS.
Yep.
Amanda Pritchard noted this could be done, but stressed difficult decisions would need to be made with significant implications, including on electives. Did you understand that to mean that potentially a suspension or certainly a slowing down of elective care? All right.
Yes.
And then you say, you queried, what more could be done on staff leave and absence? Amanda Pritchard suggested maintaining flexibility while staff should be taking leave in some areas, while others will rely on goodwill and staff rolling over leave to next year.
Yeah.
No one's underestimating the difficult decisions that need to be made, but was it really being suggested that you might cancel some staff leave?
Yes.
All right. Even notwithstanding the fact that the staff had been through waves 1, waves 2, and no doubt needed a good period of absence or leave. Why were you pondering taking that step?
Well, because it's a national emergency, and at times of national emergency, people sometimes have to cancel their holidays and their leave, even over Christmas. And whilst you're absolutely right, the staff, particularly NHS, more than probably anywhere else in the country, has felt more stress and challenges, and had been through an incredibly difficult time. I think that had, as I said, with Omicron, because of the booster campaign, and other interventions we took, it didn't turn out to be as bad as some of the scenarios had suggested. But I think it's responsible to prepare for different scenarios, including worse than those that actually transpired. And I think it would have been wrong not to consider, this issue of this particular issue of staffing and leave.
And we can see there then Jenny Harry's stressed high transmissibility will mean greater levels of nosocomial infection.
Yeah.
And I'd like to turn to that topic after the lunch break. Would that be a convenient moment, my lady?
It is, Ms Carey, thank you very much. So, Sergeant, I'm sorry we have to take a break for lunch, but I promise we will finish your evidence this afternoon. Thank you very much. I shall return
Thank you.
at 2:10.
Thank you, my lady.
Thank you.